Well, this was a prospective trial retrospective analysis. So basically, 9 clinical trials that enrolled patients with very strict guidelines about monitoring for ILD and when you had to hold drug and when you could restart. So this is in contrast to a recent real-world analysis we presented, where you're really just looking at collecting data from patients who were treated out in the community. And the importance of this analysis is that we really know what happened to all of these patients. So it does help in terms of how we should optimally evaluate our patients for ILD and how we can really understand the benefits and potential risks of retreatment. So this is really helpful. And I think the bottom line is that what we showed was that retreating after recovery from grade 1 ILD was not only safe, no one died from ILD. The events were low grade, and patients benefited by staying on treatment for, in some cases, more than a year. Well, so the recurrence isn't really a big issue for patients if you can treat it and stop the drug and it goes away again. We cause nausea, it recurs, diarrhea, neutropenia, all sorts of toxicities. So we're used to managing and monitoring for them. The concern with ILD for T-DXd is that we want to make sure it stays low grade and that there's no mortality risk. So what we were able to show was that the rate of grade 1 ILD in this pooled population that included a number of different cancers, but the majority had breast cancer, and the rate of grade 1 ILD was just 9%. That's part of the overall percentage range, which ranges from about 11 to 15%. In those patients who had grade 1 pneumonitis, some patients, by the time they recovered, might have developed progressive disease or had other issues. So about a quarter of the patients were retreated. And again, this is when the drug was really new. So what we want to do is help people feel much more comfortable about this approach. We showed in a real world retrospective analysis at ASCO in 2025 that if you gave steroids, even low dose steroids generally use 0.5 milligram per kilogram, that patients recover much more rapidly. And that's what I generally did when I was treating patients, even on our initial phase 3 trials with T-DXd. And then you re-image, and if the ground glass opacities that are asymptomatic have resolved, then you can retreat. Some of these ground glass opacities might be due to asthma. The trials were going on during COVID. You can never really be 100% sure, but you want to protect our patients from having symptomatic or even fatal ILD. So when the CT clears, the question was, if you give the drug again, does the toxicity just come back all over again? There's a big question with immunotherapy, for example. But what we found here was that in patients who had grade 1 ILD pneumonitis, that you could retreat safely if it resolved. And even though a third of the patients had recurrent ILD, all of the events were grade 1 and 2. They all recovered. And some patients were retreated 2 or 3 times. And patients were able to stay on treatment for a long period of time. So overall, this is a win-win situation for our patients. It's a great question because I think we don't have complete equipoise on even monitoring before patients get ILD. If patients have a higher risk situation, heavily pretreated, we probably won't see that as much anymore. If they're older, have renal insufficiency, patients who've had prior pneumonitis from other drugs, we encourage at least the first couple of scans when you start the drug to be every 6 weeks. But then we go to every 9 weeks. And after a longer period of time, given the fact that almost all of these cases, close to 90%, occur in the first year, we go down to every 12 weeks in monitoring, certainly at 1 year and sometimes earlier, depending on the patient's risk and situation. So what do you do after somebody's recovered and then you retreat them? If they're in that high risk category, and I've already dose reduced, for example, because of other side effects, they're elderly, have other issues, I'm going to check the first CT at 6 weeks. But if somebody is of relatively lower risk, had asymptomatic ILD, quickly improved, I'll start monitoring at about 9 weeks, because I think that you, in that situation, are really catching patients who might have an early recurrence, and therefore managing safety as well as efficacy in the best way possible.